I'm very happy to be part of this first Congress, which you have organized very good. So I'm proud to stand here. And the presentation is very hard for you, I think, because it's all biochemistry. So it's not easy. But you've eaten a very good meal, so you can just go on. Okay? So immunometabolism and tumor microenvironment, what is relevant? So, in resting cells, there is a catabolic metabolism. The energy production mainly is done by oxidative phosphorylation, which is called OXPHOS. Glucose, fat acids, and amino acids are substrates. In proliferating cells, the anabolic metabolism is changing. It's glycolysis for energy production, and the glucose and amino acids are the main fuel which they get, the proliferating cells. So they are building blocks for lipids, nucleic acids, and amino acids. The goal is energy production. Now every cell needs ATP and they want to grow. In a key pathway is the glycolysis, which is done by the pyruvate, which is converted to ATP. Anaerobically into lactate, and normoxically into acetyl-CoA, which fuels the Krebs cycle, which means that is done for fatty acids. OXPHOS, you all know that, biochemically is a target in the mitochondria, in a membrane, which needs NADH, FDH, cytochrome C, and this is the main target of a normal cell, to get fuel, to get energy. Yeah? This is called oxidative phosphorylation. The normal beta oxidation is done by the acetyl-CoA and redox equivalents. The fatty acid beta oxidation provides large amounts of that, and this is oxidized by the respiratory chain, which is called ETC, the electro-transport mechanism in the inner membrane of the mitochondria. In the tumor metabolism is quite different, because the most important characteristic of tumor cells is metabolic reprogramming. Glucose is metabolized even in the presence of abundant oxygen. That means the tumor cells don't need, or they don't use the glucose for oxidative phosphorylation, but they just produce lactate. And why it is so, I will tell you later. Though this is called aerobic glycolysis, and this is the Warburg effect. This is a Nobel Prize, which has been detected 57 or something like that. What?
32.
32. Thank you very much. And the reprogramming is thought to facilitate survival and growth of transformed cells. So the cancer cells, they use two types of metabolism. This is very special. This is the PY3K ACT-mTOR signaling pathway. And the mTOR is a very, very big proliferating intracellular pathway, which is, for example, changed by metformin. Metformin acts on mTOR, and that's why we use it for anti-cancer therapy. Yeah? Everolimus is evaluated for mTOR inhibition. So it's a chemotherapy which is established, but you can do it also with other things. Metformin is quite good for that. They stimulates the de novo synthesis of cellular building bricks, and that's very important. The other one which blocks PY3K is P10. P10 is a tumor suppressor gene, which is very often a thing that is changed in a tumor cell, which stimulates, when it's changed, the proliferation of the cells. So it inhibits the cell growth and proliferation. We are the PY3K ACT-mTOR inhibitor. And the problem is that it's often mutated, and this leads to permanent biomass proliferation. So we can think about blocking it, and then it's okay. An alternative mode is the undernutrition poor conditioned alternative. Then nutrition resources are mobilized, protein and lipid macromolecules. And what's the very important thing is that the tumor cell is able to ingest fuel by penocytosis, which means that cell debris around the cell is just incorporated and they use it as fuel. So that's very important. And if you don't get the debris, the cell debris away from a tumor area, you will always stimulate the tumor proliferation. And that's why omega-3 acids are so important, because the oxalipines are stimulating the process of getting rid of the debris. And that's very important. That's why I use omega-3 acids everywhere. Me, myself, my son, which is very, very intelligent. I would think so. Hopefully he's doing well, okay? And what is very important, it has something to do with KRAS. KRAS is very mutated in pancreatic cells. And what's very interesting is that the KRAS mutated, it's about 95%, they all are able to be blocked by ketogenic diet. So you should lower the carbohydrates, the sugar, and PDAC cells, and that's very important. I've done something with Kurt Musseter, which is the glucoplan, who has done the glucoplan, and I use it in my hospital as well. It's just looking for sugar, fructose, and just leave it, and give galactose and fatty acids and proteins. That's it. Normally, cells, the tumor cells normally form non-essential fatty acids from glucose and glutamine. And glutamine is very important. You have to leave it. And many people do think that they give glutamine for the small bowel and for the enterocytes just to renew it. It's the most horrible thing you can do in a tumor patient, because glutamine is the essential protein or amino acid which the tumor cell needs for growing. Yeah, you should leave it. And there are some fatty acids which are incorporated. I won't go deeper in this. There are many different ways where you can get the fatty acids into the tumor cells. And what you just have to keep in mind is you can't deplete a tumor cell from getting fuel. It's impossible. Yeah? The tumor cell is so intelligent that the tumor cell does everything to get it. It's just like a crack. Yeah? So this is the overview for the first, which is very important. A normal cell, they don't do glycolysis. That's Warburg. That's tumor cells. OXPHOS is a normal cell. The tumor cell is not able to do the oxidative phosphorylation. Will not be able to do that. They need nucleic acid synthesis. They do the lipid biosynthesis and the proliferation. So tumor cell is the cell which does everything on its own, and we can do nothing against it. If you look at a tumor, you might say, oh, okay, this is a mass of cells which are tumor cells, and if you look at the pancreatic carcinoma, PDAC, it's just very condensed. I did this in the university. We always puncture the pancreatic cancers to get the cells for you. and then we tried, and you always felt this is like a wall. It's very hard, and I could never believe what Dr. Professor Wirschow said, because the tumor cells are not alone. This 50% of the tumor mass is just inflammatory. It's not tumor. And the inflammatory cells might be very important for tumor destruction, but as we see later, the tumor does its own to combat it. Just produce things that diminish the immune system for himself. So the cells which you have are stellar cells, fibroblasts, adipocytes, lymphocytes, macrophages, endothelial cells, altered vascular cells, and neoangiogenesis. There are so many things around, and more important are tumor stem cells, because they are always there and they are always growing again. If you think the tumor is vanished, no, it is not, because the tumor stem cells are still alive. For example, prostate cancer. If you take the prostate off, there will be some tumor cells around which can proliferate. And that's why the prostate cancer get hormone sensitive, and then you can't do anti-hormone therapy because it's resistant. Yeah? Breast cancer. First time it's estrogen, progesterone positive. The next metastasis in the liver is just the other way around. So you have to think about that. And this is kind of tumor cell debris. If you do the chemotherapy, the cells are dying and they are lying in the tumor. And if they are not taken away, it's fuel for the tumor cells, which are stem cells, and they will grow. So let's have a look in the immune system in the tumor. That's very important. We all learned there are T cells, there are B cells, there are stem cells in the bone, the marrow. But if you look at it closer, it's just Pippi Langstrumpf. Yeah? I will do my world like it's mine. And this is a tumor, because he's able to hide PD-L1, CTLA4 like a little child. Yeah? He's playing hide and seek with us, and the immune system is not able to recognize it as a tumor cell, because there's a head on, and if you take the head away, there's a Nobel Prize for PD-L1 in 2018 for the detection of PD-L1, and now we've got the immune checkpoint inhibitors, and they work, but they work only for a short time. And that's a problem in the tumor therapy, actually, if we do the antibody therapies. It's so pricing, yeah? 5,000 for infusion. And half a year later, the tumors won't respond anymore. And that's why the tumor cells, they just change. We've got one signal transduction which we block, and there are 40 beside. And the tumor cell will recognize it, and they will say, okay, the one is blocked, I will use the other ones. And that's very important, that we fight for broad spectrum of intracellular blocking, because the secondary plant nutraceuticals, they all have indole, resveratrol, curcumin. They all have many signal transduction ways which they can block. And we can give an add-on to the normal medicine. And that's very important, that we transport this outside. Because one way is not enough. And we see it. They combine it today. There are multi-kinase inhibitors. There are many things which we combine nowadays, because we know that's not enough. A PARP inhibitor will lose its action in half a year. And then multiple myeloma, we know that the hyperthermia is very important to restore the ability of PARP inhibitors. There has been a publication in PNIS. So we know that we can do something. I asked Heidelberg for doing a study together. They are not interested in, because they don't earn money with me. That's a problem, yeah? Because I can't give them 1,500 euros for a proband. Yeah? And they have to, the study center has to be fueled by money. And I don't have it. And if it works, it's a cheap way to get rid of the problem. That's a problem for me. So we know the PD-L1, the CTLA4, we know everything. What about the immune cells? This is the picture we have to draw nowadays. It's very complex, because you have, in every kind of immune cell, you have pro and anti-tumor immune cells. The M1 macrophages are totally different from the M2 because the M2 ones, they will fuel the tumor cells. And the tumor will say, you have to get into this direction and not M1. If you take omega-3 acids, you know that you can switch. That's the good thing about the oxalipines, about the resorvils, marasines, and name it. They will change this towards anti-tumor activity. Dendritic cells, there are two ways, the plasmacytoid dendritic cells and the CDC1, they are totally different. And we know that because we've gained a lot of data about the immune system which can go for the tumor. The same with natural killer cells. There is not one natural killer cells because one will help the tumor to live and the other one will be able to kill him. And the tumor is always aware of that and produces things that will have this side. Tregs, Th2 cells. This is the differentiation between the immune cells we know nowadays. We are not able to do to have things that change it, but we know about that. The tumor cells metabolism has a decisive influence on the differentiation of immune cells in the tumor cell stroma. There is a nutritive competition, and I will go on with the amino acids, but later on, the T cells, they produce, they need cysteine, arginine, and tryptophan. But we will see later on that there are some mechanisms which deplete them, and the tumor is active. Yeah? So the next thing is release of immunosuppressive metabolites, for example, lactate, infiltration of T cells into the tumor tissue, which is actively prevented by the tumor cells. We have a defect in antigen presentation of dendritic cells. This is caused by lactate, fat accumulation, increased fatty acid oxidation, and oxygen deficiency. And the immigrating immune cells inhibit the immune system instead of activate it. So we've got a defect which is supposed on the chemotherapy. If I do chemotherapy, I've got leukocytes which are about 2,000. That's not an active immune system, that's defect. And I've got the tumor which is supposing it. And if you don't know about these things, sometimes you don't know why it doesn't work, but you have to think about helping the patient getting rid of this defect immune system. This is our therapy, our complementary therapy can support this in part. Not at all, but in part. So the immune system, the immune metabolism of the tumor modulates the response to this therapy and the outcome of the patient. The cause of aerobic glycolysis is changes in mitochondrial functional status. So upregulation of rate-limiting enzymes of glycolysis and intracellular pH regulation, loss of p53 function and presence of hypoxia in solid tumors. And one of the most important things is HIF-1 alpha. It's a hypoxia-induced factor which activates glucose transports into the tumor cells, glycolytic enzymes, and last but not least, proliferation of the tumor cells. So in normoxia, the prolyl 4-hydroxylases, PHDs, hydroxylate proline residues on the von Hippel-Lindau protein. This is the one over there, which in turn binds to HIF-1 alpha, targeting it for ubiquitination and degradation. Ubiquitination and degradation is very common in the cell, which means get rid of something you don't want to have. In tumor cells, in hypoxia, the PHDs are blocked. So the HIF-1 alpha stabilizes, and we got something like cell proliferation and survival, angiogenesis, erythropoiesis, apoptosis, proteolysis. So this is the status the tumor is in. The HIF normoxia, the tumor produces lactate. There is a surrounding in the tumor microenvironment, which is acid. And in acid, there's hypoxia, and this is the effect. The net effect is that HIF-1 alpha is stabilized, and the machinery is going on. So, translating to the tumors, we know that high amounts of HIF-1 alpha and GLUT1 is associated with a poor prognosis of cancer patients. You can see it in many publications. It supports hypoxic tumor cell energy supply, driving anaerobic glycolysis, Warburg, by upregulating monocarboxylate transporter MCT4. And HIF increases the expression of PD-L1. And PD-L1 is the thing which is a cap on the tumor cells. Yeah. The growing tumor cells increase the uptake and synthesis of glutamate as an alternative carbon source, and for this the creep cycle is going on. So what I just want to tell is that the machinery of getting energy is quite different from a normal cell, and it's just isolated from everything around. The fueling of the tumor cell is done by fatty acids and something else. Glutamine is actively ingested by the tumor cell via transporters, and what you can see here, the uptake of glutamine into the tumor cells is in turn determined by its lactate uptake. It's a co-stimulus. This increases glucose 6-phosphatase dehydrogenases and glutaminases, and one of the very important things is the oncogene c-MYC. The c-MYC expression induces the transporter SCD2 and glutaminase, and therefore the glutamine uptake in the tumor cell is self-regulated by the tumor cells, and it's just a feedback loop. It goes on and on and on, and glutamine, the exogenous supply with glutamine is very important to stop. I always see patients which take amino acid concentrations. I will produce something with Mosita where we will get a protein drink without any glutamine or fatty acids which stimulate the loop. We need non-glucoplastic amino acids and butyrate, and then it will work. I will go a little bit further over that because I think it's not so very important. What you should have in mind is that cancer-associated fibroblasts surrounding the tumor support the tumor with fuel, with amino acids, with lactate, with glutamine. So he's just working with them instead of get rid of them. So it's a close relationship between the desmoplasia, the tumor surrounding, and the tumor cell itself. Another very important thing is L-arginine. It's a multifunctional amino acid, high concentration of intracellular L-arginine reprogram metabolism from glycolysis to OXPHOS in activated T cells. So L-arginine is very important for our immune system because T cells need L-arginine to grow and to be activated. So what we think is L-arginine is a very important amino acid for our immune system. And in this case, we will say, okay, we have to give it. I'll show you something else, because arginine deficiency blocks T cells. They have arrest in the cell cycle on the in a GO1 phase, and the proliferation is decreased. So if you see this picture, you have to say L-arginine is very important for us to give the tumor patient. What you don't know, or many people don't know, is there is an arginase 1. And this arginase 1 is turning the thing around, because if you give supply for the immune system, the arginase will deplete arginine. And it has been shown in ovarian cancer, for example, that ARCH1 inhibits the T-cell proliferation and is not beneficial for the immune system, but for the tumor. So the CTLs, the cytotoxic lymphocytes, will not be able to kill the cells. They just blocked by the arginase. So we shouldn't give that because we stimulate the tumor cell growth. Another amino acid which we have to take care of is tryptophan. Tryptophan is very important for the brain. It's a dopamine, and many people do tryptophan for depression, which is very common in tumor patients, and I think 5-HTP is very good. Take it, it's a natural product, it's an amino acid, you can take it, everything will go well for the brain, but not for the tumor. It decreases the essential amino acid. The problem is that if you give tryptophan in a tumor patient, it will be converted in quinoline. And this is not good because quinoline is the main fuel for tumor cells. So if you give 5-HTP orally, you will feed the tumor. And that's not very common in our brain because you think you do something good, and the tumor thinks, thank you, I will grow. So this is very important to keep in mind. The indolamine 2,3 deoxygenase, which is expressed in tumors, will cut the tryptophan into quinoline, and this is one thing that stimulates tumor cell growth. And on the other hand, the L-arginine will kill you the immune system, the aragonase, because it's down, and if you feed this, you will get not rid of the tumor, but you will feed it. This is very easy. Actually, in a healthy patient, tryptophan is very good. In a tumor patient, it's not so good, because the higher the quinoline is, the lesser the proliferation, less apoptosis in CD8 T cells. The Tregs will differentiate, and these are not good for tumor patients because Tregs are anti-tumor, are pro-tumor, and not anti-tumor, yeah? As we learned before. Yeah? So with the tryptophan, you get just something that you will make the tumor be happy, but not sad. Taken together, conclusion one, it's very, very complex, but what you just have to keep in mind, glucose is not good, glutamine is not good, tryptophan is not good, L-arginine is not good, yeah, and you have to work with BCAAs, for example, leucine or valine or something like that. That's good from the amino acids. Fat acids, it's okay. You can't do anything else. And and what's very important is that you get the tumor environment a little bit less acid, and this you can do with hyperthermia. You will stimulate the blood flow, you will take off the debris, you can give vitamin D, you can give omega-3 acids, you can give everything. But you shouldn't do something with glucose. And the glucoprolam from Kurt is the very best nutrition you can have for tumor patients. So what I want to say is cells that depend on endogenous amino acid biosynthesis can be attacked by inhibitors of these amino acid pathways. There are many studies which are on the way to block the indolamine cycle. There are tryptophan inhibitors, there are many things that are on the run, but I think it takes a long way to get it into the clinical experience. The cancer cells that rely on exogenous supply of particular amino acids can be attacked by depletion of that particular amino acids, as I told, and normal cells show much lower amino acid requirements and can survive either amino acid biosynthesis inhibition or amino acid depletion. That's very important to keep in mind. The normal cell is much more strong than a tumor cell. So we can change a lot with the amino acids and the tumor microenvironment, and they will be attacked, but the normal cells are getting rid of. I'm doing some work with cordyceps at the moment with my patients, which is very good because it's a nucleotide, which is a false nucleotide like adenosine, and we give it in a high dose, and it works well. I think it's very good. So conclusion 2, we have to keep in mind, and that's the end of my talk. We've got a change in the glucose metabolism in the tumor cells. We have to keep in mind that we can't change many things, but we can be aware of arginase, we can be aware of the indole 3 and 2-3 complementary system, and we have to leave tryptophan as antidepressant, and the rest will do the tumor on its own. We can't do everything, but we can help. Okay, I think that's the end of my talk, and I hope you enjoyed it a little bit.
Thank you very much for your fascinating presentation and the insights in the metabolism of tumor immune system. Very interesting. Also the amino acids. So normally people focus only on glucose, but it's more complex.
It's very complex, yes.
Are there any questions or comments?
Have you tried?
I can hear you. It's no problem.
No, should be working, yeah. On a metabolic basis, have you tried to inhibit glutamine?
No.
Somehow? Thomas Seyfried does by using DAWN.
Yeah.
What are your thoughts about that?
Yeah, I think it's good. As you have seen, it's very important to inhibit and to get rid of it. Okay, but we are doing, because the problem is we're a big clinic, and I'm not able to do any studies with this limited personnel. So it's very hard for me. I would have to do it on my own, and without studies, I don't do experience in patients. It's just for us. The newspaper is very, very proud to have very informative things about our clinic. So we will be back.
A second part will be: have you have any negative effects on your ketogenic diet?
No, never ever. There are very good reports where if you do the ketogenic diet, you have to define ketogenic diet. We don't do 5 to 10% sugar. We look a little bit moderate, and if you got a pancreatic patient, cancer patient, you have to keep that he's eating anything, okay? So we're a little bit liberal. But if somebody wants, I think the glycoplan by Kurt is very good. You can look at the internet. It's red, green, and yellow, and you have just to choose things you can eat. Yeah, it's very easy to do it, and it's not only for cancer patients, mainly for silent inflammation and something like that. He's tried to implement this glucoplan, but I use it because it's very easy to follow, and if the patients stay on it, it's great. Yeah.
By Kurt, you mean Kurt Moseter, right?
Yeah. Sorry.
So
Yes.
Sarah once.
Thanks for pointing out the role of quinorenin, which is a substance I've been very interested in for a long time, coming from inflammation. And I did a very small case report, I don't know if you know that,
No.
on quinorenin and the ability to block it with Tibetan medicine.
Yeah.
Padma 28,
Yeah.
So I saw some really good results. It was not in
Great.
tumor patients, but in inflammation patients. But maybe that's
very
an
good.
idea.
So we can
Yeah.
just go on with the talk later on.
Thank you very much again.
You're welcome.
Es gibt keine Patienten, es gibt keine Therapeuten, es gibt nur Menschen.